Axial Spondyloarthritis, A Management Insight by Professor Ahmad, an epitome of knowledge in the field of rheumatology, MBBS, FACP, FACR, FCS, Internal Medicine, and FCPS Rheumatology, currently serving as Professor and Head of Department of Rheumatology, Institute of Rheumatic Disease at Central Park Medical College, Lahore. He is Consultant Rheumatologist, National Hospital and Medical Center, Co-Chair and Founding Board Member, Arthritis Care Foundation. He is President-elect, Pakistan Society of Rheumatology, and has been contributing extensively to teaching, training, and research in the field of rheumatology for more than 20 years. He has co-authored 25 publications with a special interest in the epidemiology of rheumatic diseases, spondyloarthritis, and lupus. He is also a fellow of American College of Rheumatology and has been the participant of American College of Physician International Fellowship Exchange Program Award for 2014. The stage is all yours, sir.
Assalamu alaikum and a very good morning to everyone. Thank you for this kind introduction, Hina. So it's really a pleasure and honor for me to be here this morning. I'm really indebted to Professor Saeed Akram, Professor Aftab Mohsin, Professor Azizur Rahman for having me and giving a niche to rheumatology, which I believe every primary care physician sees 15% of the patients with musculoskeletal diseases in any setting. So I will start off with a disease which is actually relevant to many specialties. I thought first time I'm speaking in this forum, so why not start with a disease which manifests in the form of a back pain. With a raise of hand, I can find out how many of you ever had an episode of back pain which lasted for a couple of days? How many of you? So, Dr. Solat, so good to see you, sir. So it is so common. So by the age of 50, so 85% of you would be having actually at least one episode of a back pain. And now see whether this back pain can be an arthritis or a spondylitis. So I have no conflicts of interest as far as this presentation is concerned. This is my outline of the talk. I would be talking about spectrum of axial spondyloarthritis with the help of two case scenarios. So, and then we will be moving to role of MRI in the management of these patients with spondyloarthritis. I would be talking about the recent management guidelines and especially individualizing these guidelines to our own settings, and then talking about our local data. So in this morning, I have heard a lot about, yes, we should come up with our own guidelines, but until we don't have our own data, we simply cannot frame our own guidelines. Again, we would be relying on the work which has been done somewhere else in the West. So moving on to my first patient. So this young 28 years male was just a week before in my clinic. And it was heartbreaking to see this young man in a wheelchair. He's just 28 years of age. His illness started when he was 13 with pain swelling in both knees, which remained there for a couple of months. And he was diagnosed at that time by a primary care physician as rheumatic fever, was treated with benzodiazepine for many years and months. And then at the age of 18, he developed low back pain and then pain in both hips, initially in the left and then right. And he was limping at one point and then was confined to wheelchair. So this was what exactly happens. He had ESR, he had at least visit to 10 orthopedics, 2 neurologists, 5 to 6 quacks before he was actually seen by me in the clinic. And there are neurosurgeons as well. And there was MRI as well with this boy, which was actually showing just indentation of thecal sac at L5S1, and he was even offered a surgery by a neurosurgeon, which actually he never required. And this house MD visited me a lot, and he always thinks of infection and saw sepsis, tuberculosis in our setting. And yes, this boy ended up with ATT as well for 6 months with no relief of symptoms because he had high CRP, high ESR, and the physician thought that he might be having a bone TB. This was his X-ray looking like. Just look at this X-ray. So this is what a grade 4 sacroiliitis, completely fused and ankylosed sacroiliac joints. Look at the hips, they are all like eaten away. There is no cartilage left. This is like bilateral grade 4 osteoarthritis of hip joints. This is what exactly we used to call previously ankylosing spondylitis, and now we say this is radiographic axial SPA. Because this spondyloarthritis is a disease which can involve peripheral joints as well as it can involve axial skeleton. But when it is predominantly involving the axial skeleton, it is called axial spondyloarthritis. And when patient has a radiographic evidence of sacroiliitis on X-ray, it is called radiographic, which is actually the same disease which we had been reporting as ankylosing spondylitis for so many years. So my second case is another young male who's a 24 years young boy, still a college student, was brought in with 3 years history of pain in his lower back, which was worse in the morning and used to get better with activity, associated with stiffness in the morning. At times he had to really wake up at night with nocturnal pain as well. His physical examination revealed some tenderness on sacroiliac joints, and there was some limitation in forward bending as well, which was depicted by modified Schobers of 13.5. He had tenderness in this Achilles area. These diseases, they involve not only the skeleton axial, but they can also involve the enthesial sites. Entheses are the sites where these tendons and ligaments are originating or are getting inserted into the bone. So this is what Achilles tendonitis would be. His neurological exam again was unremarkable. This was his X-ray like. Look at this, very nicely delineated bilateral sacroiliac joints. This is X-ray epipelvis. So whenever you have a patient with a chronic back pain with onset less than 40, so you would order an X-ray epipelvis to look at sacroiliac joints, not a lumbosacral spine X-ray anymore. So this is what exactly a normal X-ray with maybe a just subtle sclerosis on the right side, which is not enough to be classified as per the modified New York criteria. So what next should be done in this patient? You would be ordering an MRI of the sacroiliac joints. MRI should be the one which is in the semi-coronal sections. I'm happy to see that there is one radiology colleague as well in the previous talk. So there has to be sections, has to be semi-coronal, parasagittal, parallel to the plane of the sacrum. And there has to be a clear instruction from you going that this has to be a T2 fat suppressed short toy inversion recovery sequence. These are the images which are the representative images and has been published just a couple of years back by Assessment of Spondyloarthritis International Society, and which actually tell us that how exactly we should be looking at MRIs. So I personally in my practice, and many rheumatologists do that, we read our MRIs ourselves. So look at these bone marrow edema, osteitis in this young boy. So there is on both sides of the sacroiliac joints, there is osteoitis, which is BME or bone marrow edema on the stir sequence, and this is the T1. The signal would be low on T1, high on T2. The signal which is high on T1 over here is actually the fat metaplasia, which is a sign of a chronicity. Generally, when this resolves bone marrow edema, it will be replaced by fat, and then fat would be replaced by a new bone formation leading to ankylosis of the joint. And this is a dotted line over here is showing that this is a capsulitis as well. Look at this erosion, which is at the lower 1/3 of the sacroiliac joint, and this edema in this erosion. So you can see active lesions, you can see structural damage as well with MRI. So the best investigation in this setting would be an MRI of the sacroiliac joints for this young boy. And this spectrum of disease is now a non-radiographic axial SPA because his X-ray was totally normal. His HLA-B27 later turned out to be positive. He had a CRP of 23. So, and this is one criteria. If you have to really take one message from today's talk is that just Google ASAS criteria for inflammatory back pain and then memorize this criteria. So these both boys, if had been seen by a good internal medicine person, primary care physician, and had this criteria been applied on them, they would have been referred in time. So age of onset less than 40. So whenever you have a patient who is young, whose age of onset of back pain is less than 40, the duration is more than 3 months, the onset is insidious, not like what started something like, started a pain which started by picking something from the floor. It is like a chronic, insidious onset pain. No improvement with rest, with pain at night, and improvement with exercise. So this is the relatively newer classification criteria, so which had been proposed almost a decade back, but really revolutionized our approach to these patients. Now, because of the availability of very good biologics, the treatments which can really arrest the disease process and can prevent people from getting from non-radiographic stage to a radiographic stage. So this is how we now classify these patients based on 2 arms. Anyone who has a back pain for 3 months and the age of onset is less than 45, you can go this way or that way. This is the imaging arm, and this is just a clinical arm in which you do a HLA-B27 first and then look for these factors, these 12 factors. And मुझे मेरे उस्तादों ने बताया था, Professor East Mohammed is sitting here, Professor Aziz was here, Professor Aftab Mohsin, history. मेरी पहली history rheumatological disorders की, Professor Aftab इधर नहीं है, so I remember he corrected me how to take a proper history on a patient with a joint pain. So, inflammatory back pain, arthritis, oligoarticular pattern, enthesiitis, history of a red eye, dactylitis, which is exactly a sign. So you need to examine, you need to thoroughly examine and listen to your patient. History of inflammatory bowel disease, family history of SPA, good response to NSAIDs. You simply, 10 criteria, you don't need even a single test, not even a single penny spent on this patient if you will give your time to this patient and will look for these SPA features. Anyone coming to your clinic with 3-month history of a chronic back pain who is young. And yes, there is a role of HLA. It is still an expensive test. It can be done in settings available now with many labs. And, but remember that in our population, so HLA-B27 prevalence, I'm working on that in the community as well. I will come up with my own data as well short while. So, and this is exactly now because of this classification criteria, we have peripheral spondyloarthritis with predominant peripheral symptoms, psoriatic arthritis, reactive inflammatory bowel disease. So these all come in that, but there is some overlap between them and the ankylosing spondylitis as well. And this body of non-radiographic axial SPA with the advent of MRI is increasing. 50% of patients which we see now in our practices, when we do MRIs, they are actually the ones who can be classified as non-radiographic if they are coming to us in the early phase of the disease. But this is the same spectrum going from one to another stage. This is a stage when you would have only a non-radiographic stage, MRI evidence with no radiological evidence in the form of X-ray sacroiliitis, and this will move on to radiographic stage, and then you will have this ankylosis. The term ankylosing spondylitis is no more a better representative term because not everyone who would have non-radiographic stage would actually develop this. Say half of them actually would 10 years down develop. So that's why, we have to really see at what are the prognostic factors, and what is the rate of progression from one stage to another. So over a period of 2 years, 10% of these patients, they will progress from a non-radiographic to radiographic stage, and from this stage to development of syndesmophytes. It means that in 10 years, 50% of your patients actually would reach here. So which is actually not every other patient, which is not a good thing to have, not a good disease to have. So because there is a lot of societal burden, socioeconomic burden, because once a young male, which you have seen, is confined to a wheelchair, whom would be a breadwinner for the family, so you can, whole life is topsy-turvy, the family who is taking care, and a lot of economic burden, and this should not happen anymore. So there is generally a diagnostic delay in cases of our patients. We had been previously saying that this disease is uncommon in females, but now the data shows that every second, third patient with this disease is actually a female. So it's no more a disease which is just a male predominant. So the female to male ratio is now 1:2. The women have a greater delay because of pregnancies and attribution, wrong attribution at times to just osteomalacia, fibromyalgia, and all over the world there is a diagnostic delay which is more in women. So before I move on to the armamentarium in our management, I would just like to give you one slide for the pathogenesis. So if you look at these cells, these are the Th17 helper cells, the Th22 cells which are producing IL-17 and IL-22, and the TNF alpha produced by the Th1 helper cells. These are considered to be the main pro-inflammatory cytokines which are responsible for the increased osteoclastogenesis, which leads to erosions in the joints, and then osteoproliferation because of the increased osteoblastic activity occurring because of rank ligand and these pro-inflammatory cytokines. So goals of management is not just relief of symptoms. It is actually maintenance of function, improving their quality of life, and preventing the radiographic progression, and minimizing their extraspinal, extra-articular manifestation, and treating their comorbidities. They are the patients who would have accompanying other comorbid. They are at high risk for cardiovascular events as well, premature atherosclerosis. So that's why we as internal medicine people should be taking care of them and not orthopedics. So I always tell my fellows, my students is that unless until you cannot give a number to your patient, how active the disease is, what is the HbA1c level of your patient, how can you have an understanding what is going on? So this is the disease activity score. This can be done in practice. We do all the time in our patients. There are 5 parameters on the basis of which this is calculated. There are cutoffs for the inactive disease, low, high, and very high. And we now even know what is meant by the clinically significant improvement, major or minor improvement, or worsening in scores. So when you are doing it in clinical research as well as monitoring in day-to-day practice, this is a very helpful tool. This is available by Access. The app can be downloaded on your iPhone and Android phone, and these are available just on your palm. So evolution in the treatment, just from NSAIDs decades back to etanercept, infliximab, adalimumab, which are all anti-TNF, setrusumab, golimumab, to availability of IL-17 inhibitors in the last 7 years. So secukinumab is available in Pakistan, etanercept and its biosimilars are available, infliximab is available, adalimumab is available on request. And now there is one another important actually happening in 2021, which is availability of the JAK inhibitors, which is now approved for ankylosing spondylitis as well. The 2 JAK has been approved, obatisetinib and tofacitinib. I will be talking about these in a short while. So what would you do? This is just an algorithm based on that, the guidelines which are the latest as per the ACR and the EULAR, that NSAIDs to be tried first in all patients once you have ascertained the diagnosis, start them on NSAID, and if not improving, if their disease activity scores are still high, move on to biologics, and then if patient is not improving, you can even think of now JAK inhibition. The mainstay of treatment is physical therapy as well. And that has to be really kept in mind, that patient associations and at times involving your surgical colleague is also important, as we have done in our patient who is the index patient 1. What are the predictors of good response? Male gender, so low BAS5, a good functional status at the time of presentation, evidence of objective inflammation. Those patients who have a high CRP or objective evidence of inflammation in the form of a positive osteitis signals in the MRI are the ones who would respond better to these biologic medicines. So now in treat to target recommendations are not just for diabetes, hypertension, they are also for RA, psoriatic arthritis, and they have come up to ankylosing spondylitis as well. यानी कि हमें अब treat करना है to the target of remission or inactive disease. So, can radiographic progression be prevented in these patients? This is a billion-dollar question. Because final outcome, if we have not been able to mitigate that, so there's no point actually having all these therapies. Yes, continuous use of NSAIDs, you people must say that I'm wrong, but in young patients who are less than 40, don't have cardiovascular risk factors, so it is relatively safe to give them continuous as compared to on-demand, because it has shown in research that exercise, physical therapy, and NSAIDs alone can also prevent radiographic progression. And there is a window of opportunity in which patient, if given anti-TNF earlier, you can just take care of this inflammation at an earlier stage. This will be all gone. You can see over here, this inflammation after infliximab is gone. So this is the latest study by a group in Alberta. So they have proven that tuber necrosis factor inhibitor reduces spinal radiographic progression in patients with radiographic SPA. The secukinumab, then another chick on the block, which is available in Pakistan, it has also shown that this has a role in retarding the radiographic progression. Rather, 80% of these patients had no radiographic progression over the period of 2 years. So this is tofacitinib data, which is promising, and that's why this is now approved by FDA in 2021. And there are some pros and cons of using it. This is the only oral agent available after NSAID. It is relatively cheap. It is an option for those who have failed at least one TNF, because it is not approved to be used directly on these patients. There are some safety signals in the research on rheumatoid arthritis and even in ulcerative colitis of increased cardiovascular events. Even death has been reported in patients, but generally our patient population, because is a young, so we can consider this medication as one of the medication in our armamentarium. But there is no long-term safety data yet, and this drug is not approved for non-radiographic axial SPA. It is approved only for the radiographic. So going back to my first scenario, this patient actually ended up with hip replacement and didn't respond well to NSAIDs and even to secukinumab, because he came very late in the course of disease. But the second patient, because he came earlier, he got the same medicine and his disease was inactive down 3 months, meaning by he has achieved remission, which is our target. So why secukinumab in our setting? Why not TNF alpha? We all are scared generally because of the low risk of reactivation of TB in patients with, who are treated with secukinumab. It's low immunogenicity, once every month use, and it is a little bit cost effective as well. I think that this observational study, which I have done in my department with the help of my fellow colleagues, which I have been able to publish last year as well, showed that almost 90% of my patients actually achieved the target of either low disease activity or remission on this medication, which is very promising and which is in line with the data from the other countries. I am part of an APLAR, Asia Pacific League Against Rheumatism registry, which is a spondyloarthritis registry, and I'm contributing, my department at Central Park Medical College is contributing site, and we have been able to show that our data in APLAR is not much different from the West, because APLAR is a diverse region, not just India, Pakistan, it's like up to Australia. So that's why you can see that the results are almost as good as Netherlands, but we in this region, because of a lot of diversity, we need to really come up with our own local data in order to formulate our guidelines. This is my last couple of slides. This is the study which I was able to do with the help of a grant from WHO in 2019. So it is a COPCOT project, which is a WHO initiative to come up with the prevalence of rheumatic diseases in the community. This was done in a community in the suburbs of Lahore, in which 5,000 subjects were interviewed in a household survey. And 1 in every 4 person had MSK pain in the last 7 days. Around 21% had spinal pain, and which is a back pain, actually neck or the back pain, which is a very high score in the community. And out of these, when we applied ACES criteria, which I said you to take, Sajid Ubaidullah Saab ne uski picture bhi li hai us slide ki. So ACES criteria, when we applied on these patients, so around 6.7% of these patients in the community, they were having inflammatory back pain. Not everyone with inflammatory back pain would have AS, but when we had subjected them to X-rays, HLA-B27, MRIs, we were able to see that around 47 out of this 5,000 patients, they had radiographic axial SPA, so which is a very high figure, 1 in 100. Previously, it was reported as low as 0.3. This is my COP-COD team, so my mentors, my acknowledgements to my teachers, and one take-home message. Again, just remember this mnemonic: eye pain for ACES criteria, and development of registries, I believe, is a way forward. Randomized controlled trials, you don't need to do all the time these trials, because we can base recommendations which might not be very high graded recommendation, but we can generate a lot of data by development of registries. And non-radiographic axial SPA and radiographic axial SPA is the spectrum of a same disease. MRI does have a role in early diagnosis. And I am happy to